attending today. I don't know where to start actually, because I've known Dr. Parag Rindani, at that time just a boy, Parag, for over 2 decades. He has evolved. And 2 characteristics that strike me. One is he knows to ask the right questions. He learns. And the second is,
sir.
I had been taught by Dr. Duran that if you want a job done, an important job done, look for the busiest person. And Parag qualifies to that description. If I need anything done, he will never say no. He will create time. The other thing is, he's matured so much that should the family need any guidance in the healthcare space, the first name that comes to our mind is Dr. Parag Rindani. We pick up the phone, call him, and he, as a magician, knows how to sort it out. I admire him purely because he's a continuous learner. He doesn't just dabble with data and information. He applies information to become knowledge. And he's grown, evolved so much that I say he has wisdom when to use his knowledge and when not to use his knowledge. His mantra for all his work is the processes should become faster, better, cheaper. Or rather, the sequence should be better, faster, and cheaper. And he has applied this mantra in all the Wockhardt institutions. Congratulations, Parag, for that. A lesser known fact is probably that I have been chairing the IMC Ramkrishna Bajaj National Quality Award since 1994. Just one. And around that time, Mr. Habil Khorakiwala's father, Mr. Fakhruddin Khorakiwala, was very active in IMC and a past president. He kept reminding me that IMC must get into performance excellence, business excellence, performance excellence. And he cheered me all the way, and that gave birth to the IMC Ramkrishna Bajaj National Quality Award for performance excellence. And one of the segments is healthcare. So Parag has been active with us at the IMC also. He never says no. He's always got time. I think you're a benchmark for that, Parag. He's trustworthy because he keeps his promises. He keeps his promises and doesn't get unrealistic about things. So I'll end over here. We have with us Dr. Parag Rindani, who's going to share his wisdom on healthcare management, healthcare quality management. And as Umesh said, the mission of this platform is to ultimately formalize the rich experience of professionals into a qualification, a quality qualification. There are no exams, it's your experience that gets channelized, evaluated, and converted into a certified qualitist experience. So thank you, Umesh. Thank you, Parag. And over to you, Parag.
Well, thank you very much, Mr. Lulla, for those kind words. I don't really know whether I've achieved all that, but I accept what you say. So I will just quickly get into the slides and I'd like to discuss a few things. But before I get into the slides, I would like to believe that there is a mix of healthcare professionals and non-healthcare professionals amongst the team. So for healthcare professionals, some of the things that I would say would really resonate well. For the non-healthcare professionals, it might be a little difficult to sort of understand exactly what we are trying to talk about, but you will agree that as patients, these are some of the things that you faced. To quickly just get into the slideshow so that I'm able to, 1 second. So essentially, my slides are visible, Umesh?
Yes, absolutely.
Yeah, okay. So ladies and gentlemen, what we're going to be talking about is risk reduction or mitigation and quality improvement. Now, the ethos of this one has to understand, this is the DNA of all quality improvement in healthcare. Essentially, the premise which I'm going to be talking over the next hour to you is about this, that healthcare is inherent and inherently fraught with a lot of risk. This risk needs to be reduced. A lot of the risk reduction activities or all of the risk reduction activities are encompassed in accreditation, provide you follow it for 365 into 3 years, rather than just what I call wo 5 din, that is the 2 days before accreditation and the 3 days of accreditation. You have to live accreditation, have accreditation as the DNA of your institution, which brings us to the concept of promoting what we call a culture of quality. Okay. And this culture of quality over time will help you identify risk, reduce risks. These risks, when monitored, will give you indicators. These indicators, when they go out of sync from within what we call the zone of quality assurance as given by Juran's trilogy, will identify what are the quality improvement projects that you have to undertake. And it is these quality improvement projects that will actually yield some intangible gains and some tangible gains, because essentially I believe that quality is an important aspect to enhance the profitability of an institution. So once again, I repeat, risk identification leads to risk mitigation. Risk mitigation needs to monitoring of those risky areas. Monitoring of those risky areas will identify deviations in the quality assurance program for those risk areas and other areas. Those deviations from risk assurance will identify opportunities for quality improvement, and quality improvement opportunities, if translated correctly through what we call the PDCA, the Lean Six Sigma, blah, 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 many other things that we work on, should technically transform your risk as the input into a profitable venture as your final output. This is the mantra of what we're going to talk about over the next 45 minutes to an hour. It's as simple as that. Quickly telling you, 1 second, slide is not changing. Sorry, Umesh. Yes. So what is risk? Risk is the probability that a hazard will turn into a disaster. You've got a hazard. The chance that it will turn into a disaster is called risk. It's the threat or probability that an action or event will adversely affect an organization's ability. So risk is the upside of risk is the chance for improvement. The downside of risk is the risk itself. So when you combine the two, technically every risk is an opportunity for you to convert it into a non-risk and therefore a positive event. What is risk mitigation? It's a series of multiple activities. If you do it well, you will be able to prevent this risk from actually hitting your organization. Risk reduction, risk mitigation, these are all words. A fancy title was required for this presentation, so I choose the word mitigation. Risk reduction is just fine for us to use. I'm going to take you through some of the risks, and all healthcare workers will be able to identify with this. On the left-hand side, you've got the risk. On the right-hand side, you've got the risk mitigation strategy. For all occupational hazards that we do, for example, for chemicals that we use in cleaning, etc., we use MSDS stickers, we train people, we have a code in place. For counterfeit drugs and materials management, we have a selection of multinational brands. This is the way we reduce the risk. We purchase from authorized vendors, we verify the batch, okay? How do we misuse narcotics? Everybody who's gone through any accreditation cycle will know about the entry, the notification, the records. FDA comes and checks, the accounting for the broken ampules, double lock and key, narcotics which have got system generated labels, which are accessed by two different people. We know that there is a high risk of abuse of narcotics. That is why we risk mitigate it more appropriately, right? Integrity of cold chain, especially with the vaccination, as you've seen, very important that we visit our vendor, we check the goods. These are all risk mitigation efforts that we put in. In biomedical department, within the radiation hazards area, appropriate signages, all of you do this day in and day out. Sign of a pregnant woman so that she doesn't enter any radiation area, keeping people away, periodical quality assurance as per the ARB recommendation, right? In MRI, all of us know about the episodes that we read in the midday and all of that, where a patient got stuck with a metal cylinder inside the MRI. So how do you switch off the magnet? How do you save people's lives? In our hospital, for example, we have now put up fire extinguishers, which are also aluminum, and therefore, if we have to go in with that into the MRI, we are able to actually circumvent it getting attracted to the magnet. So how much amount of risk mitigation you want to do is up to you, but it's very clear that each one of you should be able to identify the risk and mitigate or reduce the risk so that you don't have an adverse event within your hospitals. All of us know about electric things. I'd like to specifically talk about something that we've evolved, which is most hospitals today would have it, which is a code white, which is an acute stroke protocol. Remember that risk mitigation also comes out of the learnings that you have by way of the errors that you see on a day-to-day basis. So the first time that we had a stroke patient, it took us about 20 minutes to get the drug down from the pharmacy. So one of the risk mitigation things that we decided is that the drug should be kept handy, that the dosage, the ready reckoner should be kept handy for giving the total dose, as well as identifying what is the bolus and what is the infusion for the drug to be given in a stroke patient. Remember, in a stroke patient, time is brain. If you don't give your drug within the golden period, there's a chance that you will lose the patient. So the thrombolytic being physically there, the dose being able to be correctly identified quickly is very, very important. In fire, all of us know this. We do 5S exercises. We ensure there are designated places. We ensure that things are not kept lying here or there. We also ensure that there are no loose wires. My mother-in-law has actually banned me from coming home because she says that every time you come, you only look for all holes in the ceiling, etc. But that's how we NABH assessors are. For non-fire things, we talk about bomb threats. We have codes in place. We do mocks of such codes. For hazardous material, we keep them logged, we keep them labeled, we have material safety data sheets in place, and we train our staff to actually handle them by doing mocks from time to time. In terms of other hazmat, of course, you need to have storage areas appropriately done. Most important is dilutions, which are done only in a couple of places. Now, coming to medication, which is a huge area, we have a concept of high alert medication, where the moment you give double the dose of the medication, the patient can go into a difficult situation you may not be able to get. For example, if I take a crocin, it will take me 200 crocin tablets to go and have an adverse event. But if I take a drug like warfarin, merely 1.5 times of warfarin will land me up in all sorts of problems in terms of clinical complications. So the high alert drugs are those drugs that are higher propensity to cause problems when given as an over medication. Then there are low risk drugs. So when you're talking about medication management as a whole, the highest number of errors normally happen in medication administration. So this is one huge area of risk mitigation that all accreditation agencies look at. The risks that are there in medication management are known to every healthcare professional today in India. Illegibility, our doctors do not write legibly. That is why the medical council has now said, or the National Council of Medicine, or whatever it's called now, has said that things need to be written in capital. Our writings, our prescriptions are many times incomplete. We don't normally write everything that's required to be written in a prescription. Sometimes our prescriptions are irrational. There are other errors, or sometimes they give it to the wrong patient. Enough anecdotes about this in the Indian film industry. But what's important is that we risk mitigate by putting capitals, by having prescription audits, by integrating software so that the drugs that are required are actually given, and any drugs that may be contraindicated or where there might be drug-drug interaction are actually not given to the patient. We constantly do audits. Remember, I always tell people whom I train that the word audit comes from to listen. Our job as auditors is to constantly listen, to identify, rectify, and prevent errors. Medications are transcribed. There is a set of transcription errors, which all of us know about. When we indent medication, you could indent it for the wrong patient, the wrong drug. You could give the wrong strength or the wrong formula. I think there was a Hindi movie about this where a child before anesthesia eats and then aspirates and stuff like that. These are things that actually happen in healthcare. And therefore, the system of checks and balances, what we call the Swiss cheese model, is absolutely appropriate and should be put at every potential high-risk process within healthcare, because high-risk process needs higher risk mitigation. For dispensing also, there has to be enough risk mitigation. One of the things, I'm sorry for the double word barcode, but I couldn't stress on it enough. That's why it's written twice there. We need to barcode our medications, and we really need to do it fast. When you're administrating the patient, the nurses have their 5 hours, and now I believe there is a 6th. This is something that we need to do. Coming to clinical areas, one of the biggest things that is noted as a predisposer or a precursor for clinical errors is improper communication. Nobody can stress it enough that the only way of reducing errors is proper communication, and proper communication. Proper patient identification, identifying patients, their surgical site, looking at hand hygiene. We're actually celebrating hand hygiene day today or week this month, and multiple other things that happen in clinical areas. In the radiation areas, you need to have radiation safeguards. When you're giving blood, you need to have safeguards for that. Medication safety, infection prevention, all of these have safeguards, which most hospitals do pretty well. The problem that hits us, ladies and gentlemen, is when we forget to do things, or when we feel that at 2 a.m. in the morning, it is okay for Lisamma not to check Mr. Patel's hand band and check whether he has an allergy. That is when the slip happens. So despite multiple systems and processes, you need to be constantly monitoring your people, because that is the sabse kamzor kadi. Okay. Non-clinical risk also we discuss. IT risks today have also become very, very important. And in COVID, we've seen the importance of personal protective equipment, vaccination, and this is what we have. One thing that we don't like to talk about is the increasing potential for physical harm to healthcare personnel. Therefore, security personnel being there across institutions is also considered a risk mitigation exercise. Coming to adult medical emergencies, whether it's your ambulance, whether it's your codes within the institution, you need to have checks and balances. You need to ensure that within your crash cards, things are not expired. You need to ensure that when you're giving critical values, supposing, for example, a high potassium or a very, very low platelet count, you need to be ensuring that this is read back. Even on high alert medications, you need to ensure that there is a verbal order read back policy, which is actually practiced. I'm going to skip anesthesia because I want to come to fall prevention. Falls within an institution, nobody wants to go with additional burden of disease than the person already came in. Those are what is called iatrogenic or healthcare associated errors or harm. So when you have a patient who's coming in who has the higher risk of fall, you need to ensure that risk mitigation processes are put in for all patients with this higher fall risk. So first of all, fall risk assessment has to be done, an SOP for fall prevention, and you need to identify the patient through different colored ID bands so that he or she is safeguarded from the risk of fall. Okay. Fall screening also needs to be, fall screening also needs to look at equipment related fall prevention, okay, as well as environment related stuff, okay. One of the other things that used to happen, which has stopped a lot since accreditation got into our country in a big way. Earlier, you would read about it, XYZ government hospital mein male bacha chori hoke female bacha rakha gaya. So the risk of child abduction is another risk that happens in a hospital. And that's something which we should have with a dedicated code within the hospital so that the hospital goes into lockdown mode in case a code for child abduction is announced. The non-healthcare workers must be thinking hospital is the most dangerous place to go in. But let me tell you, the risk of dying from an unrelated medical event in a hospital is 10 times more than of flying in an aeroplane. So the risk that you face of a healthcare error if you get admitted to a hospital is 10 times that of flying in an aeroplane, because the airplane industry, the air industry has learned to identify risks and to mitigate its risk very well. It is no-brainer, hence, that every time you fly in an aeroplane, without fail, you have these lovely human beings called Hawai Sundariya or air hostesses and air hosts who will necessarily show you 20 times about do dwar piche ki or, char dwar wings ki or do dwar aage ki or. It is not just like that they say it. This is quality by design. This is total quality management, because one of the most important things in quality management is safety. We'll come to that. Okay. So, ladies and gentlemen, coming to the next part of the presentation, let's talk about healthcare quality. The degree to which health services for individuals and populations increases the likelihood of desired health outcome. You need people to go home faster. You need people to go home without problems. You need to go home without problems that you add to them more than what they had come in. Okay. So some of the things which are the tenets of healthcare quality, and the first one and most appropriate one above is safety, which we have dealt with an abundance in the previous slides. All risks, if you mitigate well, there's a high likelihood that your patient will not have an adverse event. The next few are not related directly to safety, but are relevant. Appropriateness of care, access to care, consumer-centeredness, focus on patient rather than focusing on filling in registers. Effectiveness of the care that you're rendering, and finally, efficient care. 80% of patients go home with a Horn's effect about healthcare, because the last part of their stay in the hospital, which is discharge, is normally fraught with a lot of inefficiencies. I have a case study on that, which I'll be happy to discuss. Now, whose point of view of healthcare quality should we be considering? Let's look at it. I'd like to thank my friend Apsa for these slides. She helped me out with these slides. Good clinical outcomes, value for money, and service quality is what the patient looks for. Okay. The physician who comes to your hospital to work looks for good clinical outcomes, excellent patient experience, usually with a very, very low bill, which is what they always ask for, and a conducive milieu for the physician to work in. And if you look at the health insurance perspective, they also look for good clinical outcomes, but lower payouts and retention of the patient as well as the physicians. So the common thread in all of this is good clinical outcomes. Now, good clinical outcomes cannot be married with an unsafe event within the hospital for the patient, right? So quality, let me just get all these things out. Dr. Don Berwick, 2005, president of the Institute for Healthcare Improvement, put this description as part of the, one second. He said that quality as expressed by the patient is, first of all, don't kill me in your hospital because of your mistakes. Don't hurt me, don't give me needless pain, okay? By the way, that's not do needless pain, that's no needless pain. That's part of the quality assurance that I need to improve in my slides. Don't make me feel helpless. That means nothing about me without me. Involve me in all your processes. Don't keep me waiting. The last thing people want in a hospital, whether it's the outpatient or the inpatient, is to be kept waiting. And the last and most important thing, don't waste resources, my resources or anyone else's resources. I think this can be a very, very good mantra for quality management of any hospital. It encompasses safety, efficiency, effectiveness, and most importantly, patient's point of view on all these things. But remember, essentially, healthcare is fraught with the potential to make errors. And it's about 30 years ago in 1990s that the Institute of Medicine for the first time came out with a monograph which says to err is human and we need to build a safer health system. This was the first time that healthcare acknowledged that we are actually erroneous in our processes, and that the most important building block of any healthcare system has to be the unit of quality, which is process. When we look at nephrology or cardiology, the unit that we're trying to improve in those organs, that is the kidney or the heart, is the nephron or the cardiomyocyte. Similarly, my point of view, and Mr. Lulla can strike me down, but my point of view is when you want to improve quality, especially in healthcare, your unit of quality is process. When you do process improvement, you do quality improvement. So if you want to improve quality, you need to improve process. It's as simple as that. Processes may be written, processes may be bespoken, processes may be video recorded as done by my good friend, Dr. Farhan at Rainbow Hospital. Every SOP of theirs is a video SOP. Okay, you can have any type of process, but it has to be documented, because remember, what is done must be documented. What is not documented is considered not done in healthcare. And that's where the courts always remind to chide us. The most important thing that we've learned from To Err is Human is that primum non nocere, Latin translated to first do no harm, primarily do no harm to your patients. And this is what we need to understand as we move forward in building quality as we see it further in our country. The W. Edwards Deming Institute also wrote that the supposition is prevalent the world over that there would be no problems in production or service if only our production workers would do their jobs in the way that they were taught. Pleasant dreams. If I expect every doctor and every nurse and every technician to perform without mistakes, not going to happen. The workers are handicapped by the system, and the system belongs to management. So this is something which I constantly tell my team, that all the mistakes belong to the system and the system belongs to management. In India, we are very famous for saying, system hi kharab hai. In private institutions, remember that we build the system, and therefore any mistakes that the system makes has to come back to us. And therefore, I take you back a little bit to my favorite slide, which I've stolen from my good friend, Mr. Nair, and this is Alice in Wonderland. Alice asked a Cheshire cat. These are two famous characters in Alice in Wonderland, a very beautiful story by Lewis Carroll. Would you tell me, please, which way I ought to walk from here? The cat replies, that depends a good deal on where you want to get to. Alice says, I don't much care where. Then the cat says, then it doesn't matter which way you walk. So if you are looking to have quality management as a strategy, you need to ensure that safety, risk mitigation, quality management, quality improvement are embedded in your processes by way of a top management strategy. Otherwise, quality by mistake doesn't happen. 1 time in 10, you might give the right medication to the right patient. 9 times you will miss out. When you have quality improvement strategy, there's a high likelihood that 10 times out of 10, you will give the correct medication to the correct patient. And therefore, we need to build what we call a culture of safety, which is an integrated pattern of individual and organizational behavior. The organization needs to be looking at things. This morning, I got a message from a particular doctor from some hospital who says, there's been a patient who's already been operated on a particular site. Still, the IV line has been put in that site, which is wrong. So I have doctors now buying into, which is what I call organizational behavior of the culture of safety. It has to be based on shared beliefs and values that continuously seek to minimize patient harm that may result from the process of care delivery. So we have to first of all accept that hum galti kar sakte hain. Secondly, we have to accept that hum galti isliye karte hain kyunki hum system theek nahi banate hain. And the third thing we have to put in place is hum galti sudhar sakte hain. When you accept these 3 things, you essentially epitomize the principles of poka yoke in healthcare. Identify that you can do errors, identify and make it easy to put down the error as when it happens. And third, make it easy to correct the errors. Very simple. Coming to quality trilogy, something that I truly believe in: quality planning, measurement, and improvement. Okay. Let's just go to the actual trilogy, as I love this graph. If you look at this graph, ladies and gentlemen, and I hope you can see my arrow, The first part is about quality planning, identifying what is the potential cost of poor quality, making your processes redundant to poor quality, and therefore ensuring that your cost of poor quality comes down. And believe me, ladies and gentlemen, this could be huge if it was not for accreditation processes in our healthcare institutions. Now, for example, let's take a simple example that your discharge process takes between, or let's take X-ray film reporting takes between 15 minutes to 30 minutes, which is basically you're saying that 15 minutes is just the beginning of the operation, and therefore there's a chronic waste of 15 minutes. You have some sporadic spikes where you may report 45 minutes or even 1 hour for an X-ray getting reported. This is your original zone of quality control, okay? Then you take your zone of quality improvement, put in a quality improvement project using PDCA or any other such methodology, and then you come down to a new zone of quality control with a reduction in the chronic wastage. This saving from this line to this line is your saving. Translated into tangible numbers, you see an increase in your EBITDA or doing more patients, or if you're a charitable institution, you're able to serve more patients. For me, EBITDA is not always financial EBITDA. It could also be social EBITDA. It could be planet EBITDA. It could be carbon numbers. It could be multiple things. Okay. So for me, a risk reduction strategy is perfectly coined in the word accreditation. That an organization is doing the right things, it's doing them well, and reducing the risk of harm and optimizing the likelihood of good outcomes. Okay. Now let's talk about quality improvement in healthcare, and I'm going to straight away go to the case studies. Umesh, I believe you would have about 20 minutes more.
Yes, yes.
Okay, and Umesh, I'm going to ask you to pick one of these 3 case studies. Since the patient is our end customer, maybe we'll start with the irate patient as a case study.
Absolutely, absolutely.
Okay.
I can relate to this. Yeah.
So this is a case study done at my hospital. I'm very grateful to the team which actually did this. It was led by nursing, supported by HR, doctors, everybody else. And it was a case study which we are very proud of. It's a winner of a Kimpro Award as well. So let's just go to this case study. Okay, increasing patient satisfaction. Now, you will understand, and I guess a fair number of you have been patients, and one of the areas of patient dissatisfaction that we saw in our hospital was that our patients, when they were exiting the hospital, in the exit interviews, a majority of them were talking about the fact that हमको आपके अस्पताल में नींद नहीं आती, बहुत आवाज होता है. There is a lot of noise in the ICU, there's a lot of noise in the wards, and we are unable to sleep. Doctor ने जितनी दवाई दी, हम आराम नहीं कर पाए. That is why, and there were even a few patients who went discharged against medical advice. Okay. So this was the problem statement. The problem statement was that the patient was not getting rest. Okay. We've actually done an analysis of the number of people who went in and out. A lot of people going in and out in the hospital. Let's just understand what were the objectives of the study. Okay, before we get into that. So a lot of people going in and out, tests being scheduled, medications being given, squeaky wheels, food and beverages not clearing trays, housekeeping coming to clean when the patient is trying to rest, doctor coming on rounds when the patient is sleeping. And, you know, nobody really tells things to the doctors because we respect the doctor and they're busy, so they need to come for rounds. And the patients are waiting. So a lot of noise in the areas that we were working with patients. So the patient was saying, "Mujhe neend nahi aati, I have no rest." So the objectives undertaken were to reduce the noise levels in the ambulatory inpatient floors, not in the ICU. That was a second phase taken up subsequently, and to initiate and enhance compliance to quality time of 2 hours during the day in inpatient. So we said, 2 baje se leke dophar 4 baje tak, 2 hours, we will ensure that our patients have got rest and there is lesser noise happening in the ICU. Now, remember, Florence Nightingale had said that if you want to improve something, you first need to monitor it. And if you monitor it, you need to measure it. So nurses being nurses and bhakts of Florence Nightingale, the first thing they said, let us first identify what is the amount of noise, because if you do not monitor it, you cannot improve it. So it was decided to monitor. Actual machine was bought wherein you could actually, it's called a decibelometer. So it was decided that the noise quality, which was at that time in the wards, was 70.34 decibels. It was decided to reduce. Remember, you cannot lose weight also without a target, and you cannot reduce noise without a target. So it was decided to reduce the noise levels from 70 to 45 decibels. That is the WHO recommendation for ward areas within a period of 6 months. Ladies and gentlemen, remember, you will always find a benchmark for any improvement. You just need to look for it. So initiate and enhance compliance of quiet time to 2 hours during the day within a period of 6 months by three-pronged approach. Restricting patient movements during quiet time to and from inpatient flows from 25% to less than 10%, because sometimes you will still need to move a patient. 9 people were entering patient rooms during those hours, so restricting people movement in patient rooms from 9 to less than 3. And patient feedback about noise, we wanted to bring it down to 0. Utopian, but let's see what this team did. So a questionnaire was actually formulated. The tools were there for the problem diagnosis. A decibelmeter was produced, documentation was done. We didn't use Google Forms too much in those days, so everything was documented on paper. Observation of people going in and out, who went in, why did they go in, what time did they go in, specifically for those hours was done. And an MIS report was also taken from the IT system as to when the patient was moving up and down, okay? And then the metric was, the patient was asked, did you get adequate rest in the hospital? 29% of the patient answered no, but 71% of the patient answered yes. Out of that, the people who answered no, they did not get rest. Further, 61% of these patients said, I could not rest because I had lot of noise and which did not allow me to sleep. 11% was due to illness, others was 11%, and patient who had pain was 16.67%, which incidentally led us to the next program which we are yet to implement, and that is of introducing pain management nurses in the hospital. Remember, data collection will throw light to a lot of problems, okay? What were the noise levels? There was a max of 94, min of 50. Percentage of patients moving to and from hospitals was around 25%. These were the various reasons: X-ray, MRI, CT, sonography, 2D echo, or a treadmill test, and patients being moved from the ICU to the ward, which is a standard part and parcel of any hospital. And the average frequency of people moving to patient rooms was around 6.91. So in the lower rooms or in the lower classes, it was about 9. In the single rooms, it was around 6.4, and then 5 in the deluxe rooms. Okay. Typical fishbone diagram was done. Root cause analysis was done. So there were general issues with respect to equipment movement, alarms, bells, TV, telephone, attendant conversation in the corridors. There were service-related issues related to cleaning, diet distribution, clearing of food trays post lunch, trolleys which were moving, which made noise. The processes itself contributed to many other problems, transferring in and out of the patient. There was a medication timing that was there between 2 to 4, unplanned procedures which were there, and many handoffs which used to happen because the nurses used to come on duty at 2 o'clock, and therefore the transition of the handoff of the nurse used to happen between 2 o'clock and 3 o'clock, so the patient couldn't rest. On the personnel side, the nurses needed to go for lunch. There were consultant rounds, and there were basically associates or team members within the hospital who used to talk quite loudly. So these were these were the problems that we were faced with. Of course, in this particular case, there was no way we could have done a Pareto or identified, but we decided to focus on most of the things. We did do a Pareto because we needed to focus on the vital few first. Now, everybody knows that you have quality tools, and I'd here like to refer to my guru, Mr. Suresh Lulla's favorite observation. You've got your left brain and you've got your right brain. Your left brain is the logical side and your right brain is the creative side. As you will see in subsequent slides, it is not only important to use the left brain and the tools of quality that we hear about. It's exceedingly important in change management and specifically in quality improvement, and specifically in healthcare, to constantly have out-of-box thinking, to constantly focus on your right brain. I know for a fact, and this is not advertising, but I know for a fact that Kimpro Consultants runs a program where there are both the quality tools as well as creativity tools are used. So it's very important to remember use of left brain has to be complemented or rather augmented by use of the creativity tools using your right brain. So Pareto was done housekeeping entering for cleaning, etc., was the highest reason. Noise from telephones, shifting of patient during the afternoon. These were the three main things that were contributing to 80%. Winifred Pareto, God may he rest in peace. He's really given us a fantastic tool. Okay. So these were the three areas that were first of all identified, though the other areas were also simultaneously worked on. So an acronym was made, streamlining the afternoon rest time for patients by following quiet time. The action plan included planning the handoff time, afternoon patient assessment, and medication administration so that these patients are not disturbed between 2 and 4. Of course, training and sensitization, avoiding unnecessary movement of food trolleys and tray clearances, restrictive movements in the patient's rooms to minimal, and planning and scheduling the diagnostic procedures and transfer in of patients from ICU before or after the quiet time. This was happening parallelly with the project, with the sustainability project on reduction of electricity. So our maintenance team also suggested that we should try and reduce or shut down the lights in the wards or keep minimal lighting within that time. So it also contributed to another project that was happening. So there was a standee put up across the board. I, as the CEO of the hospital, sent an awareness mail. There was dimming of lights happening. LCD, we projected the quiet time project. These banners put up across the hospital focused on stream, which is speak softly, turn off mobile phones. Remember to ask, is there anything I can do for you? Ensure that lights are dim, avoid entering a patient's room unless necessary, and minimize patient transport. It was a nursing team that came up through their nursing governance, and I'd like to compliment our chief of nursing, Elizabeth, for helping out in a huge way. They drove the project. We had the council as also contributing on this. I think at that time it was Devashri, Pearl, and Shine, all three senior professionals. The handoffs were also planned in such a way that the activities did not interfere with quiet time. So we actually shifted the time of the afternoon shift from 2 o'clock to 1 o'clock. The patient's lunch time was also moved from 2 o'clock to 1:30. Okay. So a new shift time was brought on. Our HR Mukul also contributed with his entire team. Nurses' activities during handoffs times was also streamlined so that there was not 2 times vitals to be taken within half an hour, but just 1 time, which happened concomitantly with the handover. All teams were sensitized, the diagnostic team, the HR team, the hostel, about the food delivery, food and beverages, maintenance for the light to be put off during quiet time, the nurses and everybody. But I think our major role was also played by our consultants because they agreed that their patients need rest and they decided to come before 2 or after 4. Action plan was to remove the food and all of this. So let's just see how it actually played out. Okay. So these were the things that we did. Tray clearance before 2, tea service change from 3:30 to 4, asking this question so that in case the patient needs anything, we're able to do it before quiet time, and all transference before 11. So this is the results now, the tangible results. Our patient feedback about noise being cause of inadequate rest decreased markedly from 61% to 0. Our noise levels also went down from 70 to 50. Okay. The reduction in average movement of people reduced from 9 to 2.15. It varied a little bit depending on the room. Reduction in patient movement from 23.48% to 9.91%. Okay. And basically, our patients ended up in this quiet time with a fair amount of rest. So that is just to tell you that by identification of problems which lead to the discomfort for your patient or the lack of certain adherence, to certain protocols, by focusing on these things, there is a high probability that you will be able to convert things into practice, into permanent quality improvement. Umesh, with that, I'll stop here. Rather than getting into more case studies, I would prefer that we actually get into a Q&A mode. So in case there are things that we would help people with, we'd rather help them with the Q&A.
Okay, so I think let's do that. 1 sec.
Since we don't have too many people attending, if you prefer, you can decide if you want them to ask the question.
Sure.
Dr. Parag, this is Shailesh Godekar here.
Hi, Mr. Godekar. How are you?
I am fine, Dr. Parag. Wonderful presentation. I think it's always nice to hear from you. I love your talks very much. So one question, Dr. Parag, how do we build a culture of what you said is a risk assessment.
Okay.
Okay. That's a behavior change that it has to be the part of a DNA of a person, of an organization. So how do you build that?
Okay. I'll tell you how we built it. We built it starting in the year 2000 and 2002. We started a hospital in North Mumbai, which is no longer our hospital today. But from that time, we started having people coming in from Harvard, who was our partner at that point in time. We went in for international accreditation because at that time, national accreditation was not there. And fundamentally, Mr. Ghodekar, remember that it is not something that happens overnight. You would know it. You're a leading qualitist yourself. You lead quality for Marico. I think the culture needs to take a lot of time to build. But one thing is definite. Top management has to be totally involved in culture building for risk management. If top management is seen to be saying, "Haan, theek hai, gir gaya na, uska tongue toot gaya na, theek hai na," just look at it. So I think very important that top management displays and wears on its sleeve the importance of quality management, safety management, risk management. They are all synonymous words actually. And then one other thing that has helped healthcare over the years is the participation in accreditation, national, international. Today, India has a Canadian accreditation, Australian accreditation, US accreditation, and now I believe that Japanese is also coming in. And of course, our very own National Accreditation Board for Hospitals and Healthcare Providers, which has done a marvelous job. The other thing is that industry-wide, there has to be a moment to recognize efforts in risk management. Probably the next genre of presentations that we might want to see in Kimpro is risk reduction exercises across domains, not just quality improvement, but risk reduction. Did risk reduction lead to enhancement of profitability? That is another area. And if targets are given for risk reduction, I think it helps to a large extent, Mr. Ghodekar. I know I've not answered your question, sir. Yes, sir.
Yeah,
Mr.
no, thank
Villa
you very
comment,
much.
Sir. Mr.
Yeah,
Villa has a comment on quality culture.
Yeah, yes, sir.
All the risks associated with clinical and non-clinical processes. I have a comment on building a quality culture. It's not easy. The prerequisite to build a quality culture is good housekeeping practices. To sensitize people for detecting a mistake. Once housekeeping is under your grip as management, then you move into safety. We don't need any failures, we don't need any accidents. And the tool that is usually used is FMEA, Failure Mode Effect Analysis. Now you're ready to create a quality culture and do quality improvements, etc. Second comment I have is a hospital has clinical and non-clinical processes. The clinical ones are very sensitive ones, right brain thinking, etc. The doctor must interact, the patient must be good. The troublemaker in a hospital is the non-clinical processes. For example, a doctor with a very fantastic reputation as a cardiologist, I won't mention the name, he was conducting an operation in the operation theater on a little girl, 12-year-old. Her parents had come from the village. Suddenly there was a power outage. and smack, the gen sets that were supposed to be the standby did not trigger off in 5 seconds, but in 9 seconds. The patient died. Who lost his reputation? The doctor. So the support of non-clinical processes is very, very important. We need capable processes, and a process must have planning, quality control, quality improvement in that sequence. The easy way to remember planning, control, and improvement is Brahma, Vishnu, Mahesh. I'll leave the comment over here, but quality culture prerequisite is housekeeping and safety. You're absolutely right in focusing on risk management.
Thank you, sir. Dr. Parag, I'm going to, we've received a lot of questions, as I shared with you, from people while registering. Okay, so I'm going to take, we can perhaps alternate questions, or one from the questions that we've received and the others who have joined in can ask. So let me go in for one of the questions which has come in. Very relevant one. It says, how can senior leadership reduce the risk of losing young clinical, paraclinical, and nursing talent in the changing healthcare scenario?
Okay. So invariably, when we, not a big secret, but when we engage with doctors or senior nursing professionals whom we want to get on board, invariably a few of the things that we know excite doctors. See, for whenever, and this is not about just our group of hospitals, but for most hospitals or for most doctors, while there's this sad thing that doctors only work for money, most doctors don't come on board for money. They may come on board initially for money, but then they stay for the culture. So I think it's very, very important to build a culture of clinical accountability, to build a culture of clinical safety where the doctor feels safe in his work, in the clinical work. And I think most important is that the doctor sees a pathway to progress within the institution, which could happen both by way of marketing efforts, etc. So I do believe that a culture of safety and a genial culture, a culture where people are respected as colleagues and not just looked at in a you got to do this and you should do this and you have to do this. I think that's the culture which we need to build within the institution. The day we are able to successfully, as they say, culture eats strategy for breakfast, So according to me, developing a good culture within the institution is something that is a very, very strong motivator for people to stay. I have seen it myself, experienced it myself firsthand, hence I can definitely attest to this particular fact, Umesh.
Great. So I'm going to give an opportunity for people who are there on this call to ask a question. Else, I have a whole set of questions to ask. So if you have a question, you can unmute yourself and ask or put it in the chat. Okay, so I'm going to go in for the next question which we have received. The question is, what are the key shifts in healthcare sector post-COVID-19 and impact on people?
So there was this whole move towards tele consultations, that we need more telemedicine and all of that. But we have seen, at least in our hospitals, that patients want to come to see the doctor. They, zara doctor saab nabz dekh lijiye, they want to say those words. They want to feel nice about the doctor interaction. One of the things that is coming out in a big way is we are seeing a lot of diseases in cardiac as well as brain strokes, etc. coming in. A younger population. Recently, yesterday, we had a patient, 28-year-old, who came in with a heart attack. And I think the third thing is, because of some form of neglect at home, we're seeing a lot of patients coming in with advancements in cancer. So if you've not done, you and your friends, ladies and gentlemen, relatives, if you've not done a cancer check in the last 2 years, or you've not done a health check, please go and get yourself evaluated. The words, there is an acronym called caution, which looks at what you should be looking at in terms of improvement. Please get those things evaluated, please. So yes, increasing trend of cardiac and strokes, cardiac disorders and strokes, increasing trend of cancers, and more focus on coming to the hospital rather than doing a teleconsultation. These would be 3 things that we definitely see.
Got it. Got it. So the other question is, in which possible way personnel from other departments can be involved and made participative in risk mitigation, which may eventually improve medical, nursing, and service quality?
Yeah, so coming back to the culture of safety, that's one way. You need to ensure that everybody is clued in from minute 1 on what is unsafe. And you must also stand up there and say, this is not acceptable. We will get it done. We will get it improved on. The second important thing, and there is an article which says quality is not a department. If you Google it, you will find it. So while we are all very happy that we have a department of quality, it's very nice to ensure, it's very good to ensure that every department is construed to be an extension of the department of quality. Nobody should be able to say that quality is not my job. अरे वो तो quality department 13 माले पे है, वहां पे जाके report कर दो, ये मेरा काम नहीं है. In healthcare, that's not possible. I think to Mr. Godekar's point, even in manufacturing, if you go to a plant, let's say Mahindra & Mahindra or Marico, you can't say safety is not my department. Safety, quality have to be everybody's department. Now, how to do this? You need a set of focused heads of departments who understand the importance of quality in healthcare. You need to get people to really focus on down drilling the importance of safety and quality in healthcare. If you are not able to do this, probably need a change of HOD. But you definitely need people who own up to quality and who ensure safe behavior within their domain areas.
Super. So I'll just pause for audience questions, else I'll ask the questions that we've already received. Does anyone have a question?
Umesh, can I take one question?
Your second one, right?
Yeah.
Go ahead.
Okay. Thank you, Umesh. Dr. Parag, sir talked about the reputation risks, part. So while in Marico, we have through assessment a reputation risks of a company, of a brand. Do you have a similar reputation risk quotient, through assessment of a hospital or any hospitals?
So one of the tangible spin-offs that was supposed to happen was that accreditation was supposed to serve as a parameter of healthcare quality. To that extent, today, NABH actually has got levels. So the hospital I'm sitting in and speaking to you from right now is NABH full accredited and JCI accredited, right? Now, there are institutions which have what is called entry-level accreditation. So yes, to that extent, there are levels, but unfortunately, it does not resonate with the public because the public has not been educated by healthcare. Nobody has ever told that you come to my hospital because when you undergo an X-ray, have an X-ray in my hospital, or you have an MRI, these are the safeguards that I put in, that I actually have a metal detector where every time without fail, my technician will do swoosh, swoosh and actually check whether you have metal on your body. So the problem is that within healthcare, you will have some institutions like within all industries, you've got the good, the bad, the ugly. You've got some institutions who portray accreditation only in those 5 days. You've got some institutions which feel that assessor aake dekhe na dekhe, ye quality, ye safety, ye to mera EBIDTA enhance kar raha hai, ye to mera patient safe ho raha hai. It depends on whether you treat accreditation and the safety parameters thereof as a potential for improving reputation. If you see it as a headache, arey yaar, accreditation, tier 2 cities today will always look at this. Accreditation means enhanced paperwork. So I think that's where we have not yet created, Mr. Godekar, we have not created the correlation between accreditation levels and reputational levels. But that is the way to go to my mind, sir.
Thank you, Dr. Parag. Thank you, Dr.
So, Dr. Parag, I want to, on behalf of Dr. Anup Nigwekar, who's joining us from Kolhapur, he's posted a special comment and a thanks to you and Mr. Lula. So your talk has inspired a team of young homeopaths who have attained their multi-specialty center at Kolhapur. So he's attending this with many more young members of your community. So they are all listening to you together and benefiting from it.
Let us know when we can come out to come down to Kolhapur to chat with you, sir, about quality. We'd be happy to come and have a cup of coffee with you. Yes, Umesh, any more questions on your list?
Yes. So this may be a technical one. Your suggestions or interventions for incorporating, inculcating healthcare quality concept in GME and PGME. I don't know what it means.
Good manufacturing practices, basically. So good manufacturing practices are already by definition good manufacturing practices. So there's nothing more to be improved. They already are a set of safe and quality parameters. Okay. So in fact, while healthcare has learned from aviation industry, healthcare has also learned from the pharmaceutical industry. So there's nothing much which we can improve. I am not particularly trained in GMP or, or CGMP as it's called it, but I do understand that they essentially epitomize safe behavior. They essentially epitomize quality-oriented behavior.
So I should just clarify that it is not GMP, it is GME and PGME. Okay.
Graduate medical education and postgraduate medical education. Is that the correct question, sir?
I guess that is what.
Okay, so I'm aware of certain things that are happening, and I will here invoke the name of my senior professional, Dr. Sanjeev Singh, who is now medical director of the Amrita Institute of Medical Sciences at Faridabad. He has been instrumental for the last 10 years along with Dr. Girdhar Gyani. And they have introduced now, I think the erstwhile health minister had introduced a course of healthcare quality in graduate medical education, which was supposed to start in the Delhi NCR region as a pilot. According to me, each and every member before getting out of MBBS, in the third year must necessarily undergo a course of 3 days of program on implementation of standards. To my mind, that is less of a course. It is more of a crash course in hospital management, safety management, risk management, and quality management. And it's not very expensive. It used to cost some 17 or 18,000 rupees plus GST. I'm sure the government can waive the charges for, and God alone knows that there are enough NABH assessors who can train this program across India. And I'm sure they would be willing to do it without honorarium. So I think that's the way to go. Train people in accreditation standards upfront on day one. The other thing is make it mandatory to follow these standards. If you go to the United States, while accreditation is supposed to be voluntary, it is not really voluntary in a lot of countries. If you don't pass this standard, you don't pass the bar, and therefore you don't come out and you don't get that license to kill. So that's the answer, sir.
Got it. So there's another question which says this: how can healthcare use data to predict quality issues? Okay, so the emphasis on prediction, not just mitigation.
Okay. I think that's a very, very pertinent question. I don't have an answer to that today, but I have some views on what needs to be done. Okay. The fact that you are going to make certain number of errors is an inherent fact to healthcare. The possibility of reducing errors is dependent on the culture of safety and your systems and processes. Now, one of the areas of predicting whether a particular error may happen or no depends on your run charts for the last few months. What is the indicators? You cannot suddenly expect to have a hospital having tons of errors if they were not there in the last 1 year. But prediction and saying that we will necessarily have this many errors next month, I don't think that's feasible. And predicting that we will have this many less errors next month is something that is definitely possible by way of quality improvement. So one of the studies that I did not show, which we had done in 2005 with Dr. Robert DeCosta and Prasad Nair and other people, Elizabeth and all of these people leading the team, was on reduction of ventilator-associated pneumonia. We actually knew that the number of pneumonias caused by ventilators in a particular ICU would reduce depending on the actions that we took to reduce those pneumonias. So there is a positive correlation between quality improvement initiatives and potential for errors going down. So we can predict them going down. The fact that you might suddenly come up with a particular error, nobody can predict, sir.
Got that. So I see the time is 12:16. I'm going to take, I have 3 more questions, pertinent questions. Okay.
Please, sir.
So one of the question is, which is more learning from your experience. So this question from the audience is, want to hear more about the challenges you have faced during your career and how did you deal with this challenge with better
Okay.
outcomes?
Okay.
Yeah.
So frankly, we did not face any challenges in our quality career because we were blessed with a few people who really drove us. So you know, we had a very, very senior professional in Wockhardt called Dr. Lloyd Nazareth. He is now placed in Bangalore. He moved from our group subsequently to Fortis, but that was the man who set the basics of quality in the Wockhardt system. So we were lucky that we learned with him. So I think what happened is we were at an age where there was no option, you know, but it was part of the job to do quality. That's all we did at that time, and writing SOPs. I think a lot of reduction of headaches in your career or reduction of challenges in your careers happen when you're passionate about what you do. And that was a time when quality was new across the country. We were all excited about learning quality. We were reading these standards and we were told we'll be the first or second in the country to get this Joint Commission International. We had a team from Harvard which came over and spent a Sunday with us morning to evening dissecting the monograph To Err is Human. They spoke about something called a quality culture. Ab hamare dimag mein quality at that point in time was acha ya bura. There was nothing else. Today, we managed to give it so many attributes. So I think one of the reasons why we or I or my team did not face challenges was that we were very excited and passionate about it. Today, why do people see it as a challenge, or why do they seem to have problems? Because they see it as additional work. For us, quality and work were intertwined. There was no work without quality. There was no draping a patient in the OT the NABH way, and there was no non-NABH way. There was only one way of doing things, and that was the right way. That's the whole thing, that we did not have, okay, VIP patient hai to uska armband dekho, VIP patient nahi hai to uska armband identification ke liye mat dekho. When you get to that level, and we achieved that level of nirvana very fast, thanks to Dr. Lloyd. When you achieve that level of nirvana, and let me also tell you, Dr. Lloyd was one of Mr. Suresh Lola's students. When you achieve that level of nirvana at first shot, it's like getting married to the perfect lady the first time. Everything right, first time right. So that is what actually helped us overcome challenges. And that's the reason why, sir, today for us, quality is not a pain. Quality is a pleasure. It's fun to do a quality improvement project. And that's what I would urge all of you. Do not see an accreditation as a headache. See an accreditation cycle as a learning curve. See it as something where if you get a few errors documented in your report, it's okay. Nobody's going to kill you. Take it positively, take it head on. That's my advice, sir.
Fantastic. Okay. The other question is how to make realization to top management about consequences of risk in a typical charitable healthcare organization.
Excellent question. And I also respect Dr. Dilip Nanda's question, which Umesh, I'll take without your permission, initiating quality culture at government healthcare institutions. These two are a little bit intertwined, so I'll speak together. I think it's very important to tell the management कि आप ये नहीं करेंगे तो ये होगा. Put up the business case of loss. Put up the business case that, let us say, in a charitable institution, if you are going to not do these many things, if you're not going to put in so many sterilization methods in the operation room sterilization, CSSD, the Central Sterilization Department, you're going to have so many infections and your hospital will shut down. Present a doomsday scenario, a gloomy scenario of the cost of poor quality. Identify the cost of poor quality and use my MBA finance to actually put down a rupiana pie value that, sir, this is the cost of poor quality that's going to hit you. It's going to be 17 crores next year. Aap dekho sabki fatti hai. Sorry for the language. I think that's an accepted Indian language term. It has nothing to do with any aperture. It's just got to do with the mental state of mind. So I think it's very important. Present the cost of poor quality in rupees to them. Present the loss of reputation to them. Now coming to the government, we've actually done NEBH training at KEM Hospital. Unfortunately, 60% of the professors were dosing. If the government is really serious, like Mr. Modi did in Gujarat, it has to be made part of policy. Today, 75% of government institutions do not have the legal wherewithal or licenses to run the place. But abhi kya hota hai? Who is going to monitor the monitors? So I think it's very important that government institutions introspect. They decide if they want to get their act together. That's something for the government to do. But it is totally possible. 1,800 bedded civil hospital Ahmedabad for the last 15 years has constantly been undergoing accreditation, reaccreditation, and reaccreditation. And I have been one of the assessors, and I can tell you, though it's supposed to be confidential, that it is a fantastically run place. Yes, it is busy. Yes, it may not be clean in certain areas, but essentially the principles of safety and quality management are embedded now there for 15 years. Primary Health Center Gadboriad in Baroda district in Gujarat is accredited by the PHC standard, and they are doing very well. So it is not that a government institution cannot deliver on healthcare quality. I do not agree with that. So I actually believe, and I respect what sir is talking about, training. I think Nigwekar sir is writing about that. It is possible to do it in the government. And remember one thing, all mistakes belong to the system and the system belongs to management. Remember, we are part and parcel of management of this country. We cannot shy away from that responsibility. We may work in corporate world, we may work in, we may wear ties and sit in air conditioning offices, but the government healthcare is also ours to own. Public-private partnership, Umesh, is another way in which we would be willing to partner. I hope I've answered Mr. Dr. Dilip's question, sir.
Absolutely. So the other question that I have for you is, sustainability is a very inherent part of quality.
Yes.
So my question to you is, within your organization, how have you tried to embed sustainability across not just one workplace, but the entire culture?
Okay, there are 2-3 initiatives. One is that this particular unit is a US Green Building Council LEEDs Platinum certified facility. Across our institutions, we have got initiatives on reducing the electricity load. Remember that electricity counts for approximately 10 to 12% of the cost, the fixed cost of an institution, and therefore reducing that cost also contributes to the triple bottom line: people, planet, profit. The moment you contribute to planet, you also contribute to profit. So we have reduced almost 17-18% in some of our units of cost, which automatically contributes to sustainability. In a smaller measure, even water, water saving contributes to this. But I think what's very important is we need to get our head out of this. We have started an initiative of actually reducing the goods that we use, the disposables that we use. We need to get out of this mindset that everything disposable is great. I think our doctors need to accept that, nurses need to accept that, and we need to move to that. To that extent, that initiative is something that is still not complete. We did do some amount of it, but then COVID really took us back because PPE contributed to a lot of the disposables which we had to use. But as of now, it's focused on energy saving, water conservation, and some amount of it on certain reuses that are legally acceptable.
Wonderful. Thank you. Thank you, Dr. Parag. Once again, to the audience, do you all have any questions? Okay, great. So, Dr. Parag, thank you so much for that energetic session. It was clear, and I kind of tried to catch in. You've spoken a lot, and I've tried to catch in certain learnings, and I'm going to attempt to summarize what I kind of got through the session. Okay, and I'm certain it is incomplete. Okay, but the way I looked at it is quality is not wo 5 din, but sare 365 din. We have to identify sare kamzor kadi and not be one. And the best approach to quality is quality by design. That's the best strategy. And system hi kharab hai means management hi kharab hai. That is our responsibility. We have to create a culture of quality, and which reflects not just in the EBITDA of the company, but the EBITDA of the society and the EBITDA of the planet. Yeah, so this is really I got, and in order to do all of that, you got to use your whole brain. That's the right and the left brain parts. Dr. Parag, Thank you for your generosity of time. I know you have a press conference and many other commitments after this. You've taken this time out on a Saturday morning, and our audience, thank you for taking this time out and being here. I hope you enjoyed this session. You're most welcome to write to either Kimpro or to me or to any one of us on any suggestions on topics or events that you'd like to hear from. Yeah. Thank you. Thanks a lot for being here. Shailesh, do you want to say something?
No, I just want to thank Dr. Parag. I think it's wonderful session, Dr. Parag. And thank you, Umesh.
Thank you.
Thank you, Umesh. Thank you, everybody, for listening in. And thank you, Mr. Lulla, for this opportunity once again. I remember, I think it was 10 years ago that I had the opportunity of giving the then keynote address on the first ever introduction of healthcare quality to Kimpro Convention. And I think to that end, you will also agree that both Kimpro Convention and Indian healthcare has really improved in healthcare quality. So thanks to you for that, sir, for that lovely push.
Thank you, Parag, for your good words.
All right. Umesh, with your permission, we can sign off.
Yeah.
Thank you very much.
All the best. Bye-bye. Bye to everyone.
Thank you.
Thank you.